convey my thanks to the organizers for inviting me to this esteemed annual conference, and thanks, Chairperson, for those kind words. I would be speaking basically on, it's a hot topic today. It's gliptin, gliflozin synergy. Almost every pharma company is now coming with a combination of DPP4 and SGLT2 inhibitor. So it's a kind of an ideal marriage, or ideal couple, we can say, DPP4 with the SGLT2 inhibitor. We all know diabetes is a progressive disease, and there it is not only hypoglycemia which matters, but overall its other holistic approach has to be there. So blood pressure, lipids, and then weight management also is important. Now, other important point is now the approach is changing from glucocentric to basically protection or organ specific approach. And their heart and kidney, basically 2/3 of diabetic patients die of cardiovascular mortality, and now cardiovascular mortality is coming down because of good interventions. So kidney problem are going up, and both are going hand in hand. So one point which you all have to understand is diabetic patients, if they have a CVD, you must investigate the patient for CKD, and if patient is having diabetic patient CKD or DKD, investigate the patient for CVD. So both go hand in hand, and generally one is missed. Now other important point is that the South Asian phenotype is very typical. We are thin fat Indians, and there is increased insulin resistance in all of us, especially if you have central obesity and beta cell dysfunction. We have just discussed by the last speaker, and there is a genetic predisposition. Almost a decade or two, Indians are having a diabetes prior to Caucasians, and then obviously lifestyle modification is important. So sedentary lifestyle and other inactivity is all other reasons. What are the unmet needs in diabetes? There is a recent study, in DAB study, and one more study which has shown only 30% of type 2 diabetic patients in India achieve A1C less than 7%. So this is an important point. Why 70% we are failing despite of so many anti-diabetic agents? Other is hypoglycemia. Even one single episode of hypoglycemia in a type 2 diabetic patient makes patient patient loses confidence, and patient generally they stop medication. That is why insulin is generally is the culprit, and patient generally avoids. One is pain and other is hypoglycemia. Then weight gain. Already we have 70% of diabetic patients who are having obesity. So, and there are certain agents like pioglitazone, sulfonylureas, and insulin, they also increase weight. So we have to see to these points, and then adverse effects of the anti-diabetic agents, and then last but not least the cost, convenience, and compliance. If an anti-diabetic agent is to be given twice or thrice, patient will avoid. There would be poor compliance and adherence. So all these points have to be taken into consideration when we write any anti-diabetic agent. So basically, our aims and objectives are, yes, definitely we have to bring down A1C to prevent complications, especially microvascular complications. For macrovascular, hypertension as well as dyslipidemia, obesity, and other factors also have to be, controlled. Now, as I mentioned, the approach has changed from glucocentric to, a glucovascular metabolic, all three. So we have to get down A1C, no doubt. But at the same time, we have to avoid vascular complications and also correct metabolic abnormalities. So basically, there comes the role of agents which have a side cardio-renoprotective effects and metabolic benefits. So there, SGLT2 inhibitors, GLP1, DPP4 are the agents which are helpful. And obviously, we have to have an early and aggressive approach. We generally say early. It is never early. Even the day of diagnosis of diabetes, it is already late. Patient, the process started around 15 to 20 years prior. Action should have been taken around 20 years before the diagnosis. So it is never early. But still, when you diagnose, at least within 3 to 6 months, A1C should be brought down to less than 7%. Maximum is 6 months, and then it should remain less than 6 months, whole of life of the patient. Now this is the study, we can see here, like we can see in this study, HbA1c clinically diagnosed, it was 9.1 plus minus 2.3, very high. We come across such patients every day. And then diagnosed during screening, 8.3. So overall, average A1C of Indian adult diabetic population is 8.6, which is very high. And we are talking of bringing it to less than 7%. So generally, we treat to fail. There is a stepwise approach, one agent, 2 to 3 years, it is continued, then second, third, fourth. So basically we are treating to fail. And when we fail, then we add another agent. We never, say from, within 3 to 6 months, once it is controlled, the whole of life of the patient, it should remain less than 7%. Okay, so, we lose so many years, you can see. Insulin, almost 9 to 10 years delay is there in the initiation. And what to talk of, GLP-1 and other medications. And it has been very clearly shown in various studies that 1% of A1C reduction brings down, fatal and non-fatal MI by 14%, heart failure 16%, death from diabetes, like that is all-cause mortality 21%, and then microvascular complication 34%, even amputation and other by 43%. So just 1%. Average is 8.6. Even if we bring 8.6 to 7.6 per average, the Indian population, they can be so much benefit. Now, other important point is, it has again been seen that Indian patients, Southeast Asian, including Indian diabetic patients, the DPP4 enzyme levels are high. So we need to, that is why DPP4 inhibitors have been found to be more effective in Southeast Asians compared to Caucasians. So that's one point. So that makes DPP4 inhibitors as a good choice, and other is even SGLT2 inhibitors. So it is more of SGLT2 inhibitors, to a lesser extent DPP4. Both are more effective in Asian patients. So that makes these two molecules to be used very early. Now, if we see gliflozins, that is SGLT2 inhibitors, basically effect is on kidney. And once there is increased excretion of glucose in the urine, there is normalization of blood glucose, that improves indirectly beta cell sensitivity. And there is also basically when there is an increased glucagon level, gliflozins, they decrease early morning glucagon, but that is being compensated by gliptins. So don't bother about this small increase in glucagon which happens in the morning, and which is only for first few weeks. It doesn't continue for a long time. And then ultimately, there's loss of weight, systolic blood pressure, decreased uric acid, and obviously normalization of glucose. And gliptins, again, there's a dual pancreatic. Gliptins or GLP-1 are the only agents which have effect on suppression of glucagon, no other agent. That is why even the late stage of diabetes, they are effective. So once we combine these two, it becomes a kind of an ideal marriage, and we can address so many pathophysiological defects. So now the things have changed from prior to ominous octet. We all know that. I won't be going into detail, but important point is, once we combine SGLT2 inhibitors with DPP4 inhibitor, then almost 7 of 8 pathophysiological defects are being addressed, except the neurotransmitter, which again there are some studies where has been shown that DPP4 inhibitors have some small improvement in even neurotransmitter. So that is, like even if we exclude that, 7 of 8 pathophysiological defects are being addressed once we combine SGLT2 inhibitors with DPP4 inhibitors. Now, this is again important that metformin sulfonylurea is the most commonly prescribed combination, and it is quite powerful and good efficacy. Once we give metformin and DPP4, yes, it is again quite powerful, less than maybe a sulfonylurea metformin, but low risk of hypoglycemia. So that's an added advantage. Once we combine all three, then we are achieving even a cardio-renal benefit, weight reduction, and systolic blood pressure reduction. So many advantages you can understand. Okay. So it is always good, and now even ADA 2022 guidelines also mention that patients, irrespective of baseline A1C, irrespective, it is not patients who are uncontrolled. Even if baseline A1C is 6.5 and a patient is having CVD high risk or CVD established disease or risk for heart failure or diabetic kidney disease, give either GLP-1 or SGLT2 irrespective of A1C. You can reduce other agents because of their cardiorenal protective effects. Now, model of insulin resistance, if we see the HOMA assessment, model, there one thing is there, like as insulin resistance goes up, the beta cell function declines. So overall, higher the HOMA IR, lower is the HOMA beta function. So what we need to do is we have to decrease HOMA IR by some means, by reduction of weight. SGLT2 inhibitor is doing that. That will indirectly improve HOMA beta, so that is beta cell function would definitely improve. So overall, this is another important thing. SGLT2 inhibitors have been shown to decrease insulin resistance. We can see here an example with empagliflozin, and then beta cell function also improves with DPP4 inhibitors. So when we combine both, there is a reduction in insulin resistance and there's improvement in beta cell function, both the things. Yeah, so basically there is a complementary efficacy also. When both are given together, definitely efficacy will be much higher. And although when A1C is more than 8.5, the baseline, SGLT2 inhibitors perform better than DPP4. If it is less than 8.5, then DPP4 inhibitors perform better. But when it is higher, obviously then we start with both the agents along with metformin. So despite of high efficacy, now sulfonylureas, we keep on increasing dose. We see, prescription with 4 milligram glimepiride morning, evening. It is not required. We are just increasing the side effect hypoglycemia. Efficacy is not increasing. So 4 milligram onward, there is no increase in efficacy of sulfonylurea. We are just increasing the chances of hypoglycemia. But here when we are adding 2 molecules, there is no added increased hypoglycemic risk. Then other important point is SGLT2 inhibitors, they have an increased risk of genitourinary mycotic infection generally, and there is, the trials have shown that there is a reduction in GTIs with SGLT2 inhibitors if they are combined with DPP4 inhibitors. Probably the mycotic, the fungus which is causing this GTI, they are using DPP4 enzyme for their multiplication. And when we're giving DPP4 inhibitors, by inhibition of DPP4 enzyme, there is less multiplication. So there is less incidence of GTI when we're combining DPP4 with SGLT2 inhibitor. So overall, if we see, there is a better efficacy, more reduction, robust reduction, less polyuria and less infection, and same hypoglycemia. Now, there are some studies which is again very important. Indian central obesity, and there's a less adiponectin. This is also has been seen, and here a study was done, and where it was effect on adipocytokines was observed, and we can see here that DPP4 inhibitors and SGLT2 inhibitors, they improve adiponectin levels, and there's reduction in retinal binding protein 4, fatty acid binding 4, and wisfatin, which are inflammatory cytokines. So those are indirect effect, so kind of pleiotropic effect besides glucose lowering. Now we have many studies with both SGLT2 inhibitors, so I won't be going into detail, but overall SGLT2 inhibitors have been found to reduce hospitalization due to heart failure, cardiovascular mortality, all-cause mortality. And similarly, we have studies with the DPP4 inhibitors, and DPP4 inhibitors are also found to be cardiovascular safe, except saxagliptin, which resulted in increased hospitalization due to heart failure. That's it. Otherwise, all, yes, vildagliptin and teneligliptin, we don't have any outcome study. So that point has to be kept in mind when we write these molecules. And as far as a combination of these two are concerned, we already have some combinations available. We have EMPA and LINA, we have DAPA and SEXA, and we have Remo Vilda. But again, with Remo and Vildagliptin, we don't have any CVOT trial. So that point, no evidence as of today. So this is only, and now since DAPA gliflozin is also generic, and times to come, even sitagliptin is going to be generic after July, so there would be more and more such molecules. The only message I would say that cost is important, but never compromise with quality, in a way that all generics are not same, one point. Then you must see the PK/PD studies whenever a company comes, PK/PD profile of that generic molecule compared to innovator. So that's an important point, like we should not compromise on quality. So overall benefits of combining these two are that one is renal safety. Yes, DPP4 inhibitors, they reduce albuminuria. Cardiovascular safety, ease of use, very less side effects. SGLT2 inhibitors, cardio-renoprotective and metabolic. Reduction in systolic blood pressure, reduction in weight, and of that 70% weight loss is fat, and then decrease uric acid. So these are important, additional pleiotropic effects which sometimes become important. Even guidelines today, whether it is ADA, whether it is AACE, EAC, AAC, any guidelines you go, I think, for last so many years we've been talking, and I hear also maybe more than 10 speakers must have talked, that SGLT2 inhibitor, GLP-1, GLP-1, the only problem is very costly. We have seen in the, I think the first speaker talked, 2.7% only, are, and of those 2.7 also, within 3 to 6 months, there's a lot of attrition rate. They stop taking. Very few patients continue to take GLP-1 analog. So that is why in lieu of GLP-1 analog, we give DPP4 inhibitor. So that way SGLT2 and DPP4 become an ideal choice. So overall, this is my last but one slide. Overall, when we combine DPP4 and SGLT2 inhibitors, what we get is metabolic control, reduction in A1C of more than 1.8%, then other pleiotropic benefits, weight loss, decreased uric acid, blood pressure, cardioprotective effect, significant 3-point MACE, we have seen that, cardiovascular death, all cause and hospitalization due to heart failure, and then renoprotective. We already have DAPA, CKD, credence, and now in next month, ADA, even EMPA kidney, EMPA renal data also would be released. The top line results are already out. So basically, and that is even in non-diabetic patients. DAPA, CKD, EMPA kidney, non-diabetic also, the benefits are there. So overall, the takeaway messages are very clear that when we are, there is a clear-cut synergy between gliptin and gliflozin, and there is a robust A1C reduction, clear-cut, no added hypoglycemia, then weight loss, and most of it is fat, decreased systolic blood pressure, uric acid, and cardio-renoprotection, less genitourinary infection when you combining both, and overall, if we are having generics and of good quality compared to innovator, then obviously the cost, convenience if they are available in one tablet, and obviously they'll make more better compliance and adherence. So with this I conclude my talk and I convey my thanks to all of you.